print of UCLA around the Southern California. As you see, it's covered from Simi Valley to up to actually Harvard, UCLA. So it's very distributed, and we have the owned and operated as well as safety net partner and joint venture program that we have. That includes of over 1,800 clinical full-time UCLA physicians, and we have over 2.3 million visits in the community and more than 3.5 million visits when hospital-based clinics added. So those are a great opportunity that also is available to our members and other academic affiliates. So we are hoping together we can leverage that network to advance the field of our healthcare and in particular decentralized healthcare system. A part that is UCLA Health that is well resonates with the mission of citizenship is actually one of the top priority or goal of UCLA system that is improving patient access to UCLA Health. This is the same mission that we are advocating for citizenship. And many of the projects that we are working on the citizenship is really tackling that goal. I have a couple of examples of the project that we have done. I started at Baylor College of Medicine and we continue at UCLA. One of the earlier project that we got actually from the year one and has continued for several years in a row is empowering aging or promoting aging in place thanks to the technology by Best Buy Health. Here you see that some of our students, pre-med, residents, and other researchers that are actually contributing and benefiting with this project, and you see that each of them, they're wearing a pendant device by Best Buy. That's a personal emergency system that it detect automatically fall. It has an action button that it can reach 24/7 to someone to get support when it's needed. Also, they can now get support from social workers and getting the social needs support to address the loneliness and any other needs that they have. And we test those solutions to see that how we can promote aging in place and how we can make individual healthy. It was a challenging actually work. It was a 6 months prospective observational study. Our target, it was recruiting 20, but we recruit 21 people, and we follow each individual for 6 months, and we have 24/7 collection of the data using that pendant sensor. This is one of the I'm guessing very rich and very heavy database that we have, and we have regular follow-up with these individuals with tracking the hospitalization, the change of medication, change in the health. We know that number of time that they benefit from the service of not only the mental social care utilization, but also personal emergency response utilization that could be either for instance of fall or when they don't feel good and they need to quickly reach to the hospital. So every detail was documented for the 6 months in a row. We are crunching the data still. The study just finished, and there are several abstracts currently has been submitted. This is some of the earlier results. Again, is ongoing, but just seeing that how those technology can help make patient healthier. This is amazing results that you find out. If you look at, for instance, the baseline, is the base of the guideline that we have that of WHO about the number of days that a patient feel healthier. Of course, we target individuals that they are not healthy. They have loneliness or they have frequent fallers. So, and as you see at the baseline, for instance, on average, we have more than 12 days unhealthy days per month for those individuals. And when we start using that platform, we see that daily days actually is become less than 6 days. The national average that we expected to observe is 5.4 days. So we are hitting that goal, and we, in particular, when we are reaching to the months 3 and 4, of course, there are some fluctuation. We are saying that the people feel healthier. And in particular, the impact even is more drastic when you look at the mentally unhealthy days. So this is very impressive to see that how this social support actually can help to manage mental health. And this is important. During pandemic, we published a paper and we show that this social isolation, how much it impact the mental health and depression. So it makes sense that if we can provide this social support, we can actually manage those kind of conditions. Recently, actually, there was estimation of the cost. There was drastically healthcare saving by just using those kind of technology can provide and deliver care at home. So stay tuned for new results. I cannot disclose much results since they are under review and we are not allowed to share it publicly. Another great project that we have done in line of access to care is a collaboration with SmartTech 21. Again, is one of the earlier projects that we funded as C2SHIP. The idea is to improve communication between patient and care providers through an interactive tablet that it simplify the care plan and journey post-hospital discharge. We just published the results of this study actually earlier this year. Again, very briefly, how we tackle them, we know that 40% to 80% actually patients forget 40 to 80% of the conversation that they had in doctor visit. And many of the reason for readmission in the hospital is really due to lack of the education about a medical condition, not timely reporting the symptoms and causing the problem. And this is the way that with the smart tech, with the technology that's called personal virtual assistant, we're trying to tackle them. It provides personalized care plans, simplified care plan, and it helps to remind about medication task. It provides guided exercise, educational videos, enable real-time symptom tracking. This is very important. Number 6, I would like to highlight, this is a great opportunity for those industry that they would like to enter in the era of the post-hospital discharge. I have recently meeting with our leadership in the UCLA Health, and this is the biggest struggle that they have. Sometimes they delay the discharge of the patient from the hospital because they are worried that patient cannot very well document the symptoms and timely communicate with care providers, leading to unplanned hospital admission. But I'm not going to details, but just if you look at it on the bottom graph, we documented that how many actually, what is a percentage of the participant that interact with this tablet at least 3 times per day, and at least 5 days a week. As you see here, except week 1, then the rest of the week till 30 days post-hospital discharge, the interaction was above 80%. And we have a good compliance of the participant, except one patient who has readmitted and actually was a patient that has the least compliance on using the tablet. The rest actually have completed the journey. I'm really hoping that we can continue that effort and partner with others to scale up those kind of the technology. And actually that was beneficial for industrial members that we have now, thanks to this study and the content that has been built. Now they starting to deploying the platform in several hospitals. We are hoping that we support other industrial members that they want to go to that journey to navigate the obstacles and challenges, and also identifying the true unmet need that we have in this area. And this is the project that I would like to spend more about it. And actually this topic of my today talk is again one of the earlier studies that we have, and we got the support and mentorship by Neurometrics, Dr. Shai Gozani, for using their wearable devices to manage long COVID symptoms. And the results actually just in December published in scientific reports. I would like to talk about that journey. This is the way that, of course, it can maybe giving a better insight for those who may not be familiar with the challenges that today we are dealing with the long COVID, and also understanding that how, as a faculty, we achieve to pitch a project or industrial members, engage them, and making a real impact together. So let's delve to it. So when we pitch this project, of course, we have some experience in this area, and it helped us to bring a convincing story to industry members to convince them that it makes sense to invest this area. And that was started from earlier time of the pandemic. Uh, some of the faculty here probably remember very well when the pandemic hit, many of the research was shut down in practical clinical research. We were not allowed to recruit any patient except it was essential or it was remote care. Several of my research was impacted. Of course, I was in Texas. We didn't have necessary shutdown of or medical school. My office is in the hospital, so we achieved to continue work, even though that we didn't know what would happen to research. And as an engineer, I was lucky because I was in the hospital. I have the opportunity to interact with our physicians who were in the front line of providing care to our patient. And I remember that one of our surgeon, Dr. Lore, he was oncology, she was oncology surgeon, but she was tasked to oversee ICU for COVID patient for several days in a row. And I remember that it was her last shift. She was exhausted, and despite being exhausted, I went and talked to her, say that how as a researcher we can help you, and what are the challenges that we have, and she mentioned that actually what I'm worried about the COVID is that we have patients coming to the ICU. We don't know how long they will stay here. We have patients that stay in the ICU now for more than a couple of months. We are worried that even if we can help them survive, what would happen about their quality of life when they discharge from the hospital? We have a term that's called ICU acquired weakness. It's related to myopathy or weakness, loss of muscles, and also neuropathy, a loss of sensation in lower extremity. And those conditions, it may stay with patients for many years to come. And because of COVID-19, we cannot provide exercise to this patient, or time of interaction with this patient is very limited. So we don't have anything for that. And that was actually a wake-up call for me to say that, okay, we prior to that event, we did a research with electrical stimulation, of course, was focused for wound healing. We provide electrical stimulation, we demonstrate can improve perfusion to lower extremity, can accelerate wound healing. We use for patient with peripheral neuropathy, and we demonstrate that we can salvage a part of the nerve. Actually, before that, we have a systemic review to show the mechanism of action of electrical stimulation. And we thought that we have evidence that maybe that might be a solution that can be deployed in the ICU and can help those patients to continue to have perfusion to lower extremity, keep activating the muscles, because if you don't use the muscles, we'll lose it. And hopefully also ensuring the quality of life of those patients after survivorship. It was a bold decision from my end. When I go back, I said, wow, that was very maybe risky ideas because we didn't have yet vaccine at that time. And we applied for IRB, so we were so scared that what will happen. I was very worried for my research staff, but my research staff, all they were on board. They said that they want to do something. So we applied for IRB. Of course, IRB approval took time. And when we recruited the first patient, 2 days later, we have vaccine. And we were lucky that our team, they were very first, when the first hour that vaccine was initiated, they got the vaccine. So it gave us some safety. And we apply that technology. The technology apply, as we see here in the ICU, we keep activating the large muscles. The time of interaction with patient was minimum. There wasn't any burden on nursing staff. Just our research staff went attached to the electrical stimulation, and that said, we have 1 hour activation, and then they remove the trial. So for the measurement that we use surface EMG to look at muscle activity and muscle function, and we look at ankle strength using the dynamometer. We need to think a lot of things out of the box because we have a lot of limitation in the ICU, and we need to really minimize the time that we needed to interact with patient based of the hospital actually policy. And the results were very impressive, actually. This was a randomized control trial for one group. We provide active stimulation. The other group, it was the same functional, but just internally we modified the cross motion. We cut circuits. So simply when we turn on the system, it doesn't deliver any electrical stimulation. And the orange color here, you see that intervention group that receive active intervention, and the blue, they are control group that didn't receive any intervention. And you see that even at day 3, this is the challenges that we have, just 3 being bed bound. It actually lead a noticeable decline in ankle strength and significant decline on the muscle performance on the day 3. In control group, we didn't expect it to have improvement, but you have a trend on improvement. It seems that they have some also activation of the muscles, making the muscles more strength. And of course, we have challenged to go to day 9 because many of our patients, unfortunately, become intubated after day 3. The condition, they were worsened. So we needed again to think about out of the box to do the measurement, and we came up actually with a model that look at the muscle strength based on the amount of the muscle fiber response to an electrical stimulation. We find out that more response of those muscle fiber in the same amount of electrical stimulation can represent the muscle health. And based on that metric, actually we saw that if you look at up to day 9, we have noticeable improvements in the intervention group, but not necessarily, and we have the decline in the control group. The last score that you're seeing, MFS, this is also very interesting. Actually, thanks to our industrial members, we realized about these data and we achieved to look at from electronic health record to capture them. This is evaluation of risk of falling. When the patient's coming to the hospital, they evaluate what is the level of risk of falling. And one of the decision making for discharge of the patient and resource allocation is look at the risk of falling at the time of the hospital discharge. And as you see here, higher score means higher risk of falling. So the blue, the control group, you see risk of falling was increased at the time of the hospital discharge. They feel weaker, they have poor mobility. That's the reason that we have, but actually we have even a slight decrease in the risk of falling on intervention. So this is the part that we are hoping that our industry members can go apply for FDA and also convince hospitals for acquiring and deploying them. Later on, when we show these results, now our transplant unit, they want to use it for the patient, in particular the patient who are intubated, they cannot match engagement exercise, they can benefit from those kind of program. And I'm hoping that some of the industry members also come up with make it more elegant solution, because these challenges of the ICU accurate weakness for the bed-bound patient is a huge problem, and the exercise is not necessarily very practical to be used in the ICU and hospital setting. So that brings to the next challenge that we have was long COVID, or the scientific term is post-acute sequelae of SARS-CoV-19, or PASC. Is one of the new terms that we learned after COVID-19, and actually we realize many patients are suffering from it. Based of the statistics suggest that 1 in 5 adults present with persistent long-lasting COVID-19. That means there's some symptoms that last more than 3 months after actually healing from COVID. And that impact many organs of the body. Still, we don't know what's happening. Now, of course, the research has been emerged, but still is a huge, huge problem. It's still an impact many of our patients. If you look at the most actually reported long COVID symptoms, the top one is ear, nose, and throat, like loss of the smell and other challenges that many of you are familiar. The other one is constitutional symptoms like pain and fatigue. But the third most actually affected people with long COVID is including musculoskeletal problem. That it's really impact the quality of life of many of our patients. And there is a challenge here, and the challenge here is that actually we don't know how COVID-19 it's damaged the organ and impact the vascular system. We used to say the exercise is the best medicine, but in this exceptional case, exercise could be a worse medicine for those patients. And or early on, the exercise was recommended, and then they saw that the symptoms was worsening, and that's why the WHO guidelines then do not recommend exercising to this subpopulation, as it can lead to actually worsening the symptoms, possibly due to an impaired post exertional oxygen recovery of the patient. In other words, when there's a term of silent hypoxia, when they do the activity burn the oxygen in the muscles, and for whatever reason, the long COVID patient, they don't have a quick recovery of the oxygen supply in the muscles, and if you continue to do activity and there is no oxygen to muscle fibers, it can cause damage to the muscles, and that's a problem that we have with long COVID. So we thought that maybe we need to come up with a alternative solution, alternative to exercise, that's a less riskier for exercise and help to recondition the muscles for those patients. So again, the idea is become the same electrical stimulation. They have already evidence that electrical stimulation can aid pain, both central and peripheral origin, and can be applied to multiple sites, so we can decide where we should apply it. It can enhance musculoskeletal condition. Previously, we did a study, we demonstrate that electrical stimulation is applied correctly with the right waveform, right dosage. It can improve balance and gait in the people who has both vascular and peripheral neuropathy, and also it can enhance vascular condition, in particular oxygen modulation. Most importantly, with the electrical stimulation, we can change the use cycle and modulation to not actually consume too much oxygen supply, doesn't exhaust the muscle or lead to muscle fatigue. So we can work with that type of the waveform and creating something that is personalized to the condition of those patients. So that was our initial hypothesis, and we tested those hypotheses. We starting to this time recruiting patients who discharged from ICU. We emphasize that they should not only having long COVID, but also should be admitted to ICU for treatment of their long COVID, and they should have persistence of long COVID related to musculoskeletal data. And we apply the electrodes on the larger muscles, both legs, and we make these as the self-administrated for home use. So unlike ICU that we apply them, we educate patient, and we say that when you are using it at home, apply them, actually monitor for at least 1 hour with the intensity that we define, with type of the waveform, and then we starting to look at it, that whether we can get benefit from those kind of intervention. There is also actually published in Physiological Response, but what we measure, and also there was a new protocol of the test that we are very proud that we actually created that can be used for other exercise physiology, and using an innovative technology from one of our member of our CTSHIP Kent imaging system, that it shows very beneficial in that context. So in summary, how we measured the benefit of that therapy on changing gastrocnemic muscle endurance. And also we look at the change in plantar oxyhemoglobin during and after electrostimulation using the Kent imaging system, as you can see here. What was our protocol? We said that, okay, when we apply electrostimulation for 1 hour, we anticipate that these electrostimulation, practical activation of large muscle, should consume and drain the oxygen that even we should be able to see on the skin superficial and even on the plantar region. The plantar region is much easier for photography and make it much practical for measurement. But if we have a healthy perfusion, we anticipate that when we stop the therapy, we should quickly recover to the baseline. That means that automatically we should have resupply of the oxygen. This is the healthy behavior that we anticipate that. And actually we test this in a group of a healthy subject to confirm the healthy pattern. And we look at the literatures and they are also recommending the same method. But that was a very practical protocol that we could use the outcome. And we have, of course, many results that you can see on our publication. But this is a very impressive result that we have. Again, that was a randomized control trial, was blinded. The participants didn't know that they are inactive and sham group. And we have, again, intervention group receive active therapy, control group receive the sham therapy. So if you look at the first 60 minutes, our assumption was correct. As you see, when we apply electrical stimulation, the oxygen supply in the skin start to drop, and this is what we anticipated. The oxygen, the muscle, when it's activated, consume oxygen. But you see that 4 weeks when you provide this therapy, the intervention group is starting to have healthy behavior. We are seeing that oxygen resupplies very quickly within 10 minutes. It's come back to baseline. This is the healthy behavior that we have, but we are not seeing that recovery in the people who did long COVID. And that was similar to the baseline that we have for the both groups. So again, this is what we taught, and this is what we call it as exercise intolerance. The people who cannot tolerate exercise, the people that as soon as they do activity, they feel exhausted, they feel pain. And we believe that that is related to this irregularity of the oxygen supply in the muscles. Again, we were hoping that the same mechanism can be applied for others. This is a typical cases that we saw. In some of the cases, and we expect to observe that even when we activate, it's like that when you're walking, even we can further perfusion lower extremities, the natural mechanism of our body. And you're seeing that for those Candy mentioned, some of our participants, we have even higher oxygenation in lower extremity after this activation. This is in line of the previous study that we have done, that electrostimulation can improve perfusion and accelerate wound healing in the plantar area. And this is another interesting result that we observe about the muscle endurance. Again, we saw that muscle endurance start to be improved in the intervention group, while it didn't change in the control group, and we have a significant between groups and time group effect on our participants. And this is another interesting aspect when you look at the changes in perfusion compared to the 4 weeks on baseline. And we look at the change of endurance, and we saw that in the intervention group, there is a good correlation. It seems that the gain in endurance that we got, it was thanks to improve in the perfusion response that we have in these participants, while there wasn't any correlation in the control group. So that was very promising results. And again, this is another interesting result when we look at the ankle strength. Again, on the left side, you see ankle strength. In the intervention group, we have baseline, we have big 2, and we have big 4. You see that those participants continue to improve them, and that was reflected by patient report. We interviewed some of our patients. It was very actually heartwarming to hearing those patient testimony. One of our patients say that he was farmer, he was working in tractor. After COVID, he couldn't ride his tractor anymore. He was exhausted all the time. And actually, apparently, he regained the strength. Again, when we look at in sham group, there wasn't any difference in the ankle strength when we look at it. So it shows that the program is working. So again, that was a long, actually, story to come up with finally the idea that we pitched to neurometrics and our C2SHIP, and they convinced that that solution worked, and they find out that it's a great opportunity for them. And we find one of our company, Neurometrics, they recently got FDA approval for management of fibromyalgia using not muscle electrical stimulation, but electrical nerve stimulation or neuromodulation. And when we look at a quick review, we find out that actually 30% of the long COVID patient met the fibromyalgia diagnosis criteria. This is constitutional problem, pain and fatigue, that in previous study we didn't target them. We focus on musculoskeletal aspect, but pain and fatigue also is a huge problem with long COVID. And we thought that maybe with the product of neurometrics, we can tackle those problems. Again, for those who are not familiar with COAL, that designed by neurometrics, it was a very elegant wearable device. The same electrostimulation is attached around the calf muscles. It simplifies the use of electrostimulation. It doesn't use this sticky patch. But also through the app, you can manage the electrostimulation, and it simplifies, emphasizes on a lot of simplicity. And at that time, it was 2021. It was the same time that almost we pitched the idea. We found out that they got FDA breakthrough for treatment of fibromyalgia using their technology. And then we presented the idea to say that maybe the same solution can help to manage the symptoms of pain and fatigue or fibromyalgia-like symptoms. For those that might be surprised at how such electrical neuromodulation can manage pain, actually there is a very famous theory that supports that. This theory is called gate control theory of pain. That actually originally was proposed by Dr. Melzack and Patrick Wall in 1965. The idea of this pain gate is that they said that the pain is translated to sensory motor cortex through A beta fiber, but to see a bit of fiber, but we can modulate that signal of the pain through a signal that we can inject to a beta fiber. So we can block that gate. That means that the pain doesn't reach to the brain, so brain cannot interpret the pain signal. It can also modulate them, so it can exaggerate pain, or it can demodulate them. So there are many factors that can activate a beta fiber. If you rub your, for example, hand, actually this is a mechanism or touch that can reduce pain, or some cold sometimes reduce pain, or even psychological effect. This is guided imagery. You can, by psychological aspect or distraction, you can also reduce pain effect. And one way to activate this A beta fiber is through applying the right electrical stimulation to the nerve that can help to close that gate. So for that, we designed a double-blinded randomized control trial. Again, was 4 weeks. We inspired from previous study that we have done. We said that during double-blinded, for intervention group, we give the high dosage electrical stimulation. For the placebo group, actually the previous one, if you remember, we cut the circuit, so the patient didn't get any electrical stimulation, and the patient can know that this is not a real device. They don't feel anything, but neurometrics make an elegant way. They said that even the control group, we give electrical stimulation, but we give low dosage, so they feel some vibration, some feeling electrical stimulation, but it's not actually the enough dosage. So they got some level of intervention. And then when we finish on 4 weeks for the placebo group, we offer them that, hey, you were in the sham group. If you would like, you can try the intervention group. Actually, majority of them, they accept to have it, and then we activate the system. So we have like the mini crossover intervention that we switch the placebo to intervention to see the benefit, what we observe. We have the original patient-reported outcomes that FDA considers as a primary outcome, and also we added additional metrics like functional measurement, feasibility, compliance, adherence of the device, document the adherence of the patient as well. This is very quickly the results. It's very impressive, the results that we find out. Again, if you look at the first 4 weeks, when these actually black color, they are intervention group. Sorry, the color code, it doesn't show that, but this black curve, it shows the intervention group, and the white is a sham group. And that's a percentage of the change. Higher percentage, that means that we have less pain interference with the daily living is one of the important metrics associated with fibromyalgia. And as you see here, it is clear with very large effect size, we saw significant reduction on pain interference with daily activity. In the sham group also, we saw a reduction. We believe that since they got already some benefit because we provide some level of neuromodulation for the sham group as well. An interesting part is this 8 weeks. Again, remember in the 8 weeks, we activate now electrical stimulation for sham group, the same groups. And as a comparison, we keep the intervention group to see that whether they're coming the same level. But we are seeing that as soon as that we activate and we follow again for another 4 weeks, they reach almost the same level of the intervention group on this first 4 weeks. So it's really, it's provide a clear evidence that there is something about this neuromodulation that contribute to reduce those effect. It was very high dosage. They needed to use at least 3 times per day for 1 hour. If we didn't have wearable devices, it was very hard to implement that solution. And I believe that the fact that we have this wearable neuromodulation was really contribute to get that kind of benefit. I'm not going to the detail, but that is another interesting information that they find about objective outcomes, about gait outcome. One of the metrics that we look at was double support. It's an indicator that actually represent that it's a part of the gait when the both foot is in contact on the ground during the period that we translate the actually potential energy to kinetic energy. Efficiency during that period is very important, and also stability. It's estimated that over 60% of energy during walk is happening during that almost 20% part of the gait. And we expect that these percentage become around 20% of the total gait cycle. So we see that in the both group at the baseline, we were above the normal range of the double support time, what we have. And when we provide the intervention group, we are seeing that after 4 weeks on the intervention group, these parameters return to normal range of double support. That was very promising data. And again, for the gait outcomes was actually objective for majority of the outcomes that we got. We also look at the ease of use, perceived usefulness, and attitude toward the use for the both group. Ease of use for both group is very high, as you see here, over 90%. It's very easy. It's a wearable device. I use an app. I activate them. It's very simple. Of course, where usefulness is changed. Definitely in the intervention group, they perceive better benefit. This is what the patient feel about it. And again, we look at all other details, how it impact on their level of fatigue and others. As you see, intervention group, even their perception, they feel better than control group from what they have in mind. So, again, when we look at the days of the use, that how many days they are using the system, we have a pretty good compliance. Again, if you look at the 3 sessions per day, actually we have a pretty good percentage on the both group that they use them. Even control group, 92% of them, they use 3 sessions per day. And those are objective data. It's not self-reported data. And all the intervention group, they have 100% compliance, and 100% use 3 sessions per day. So it was very actually improving the data for the solution. And that was turned a success story, actually. We were very pleased that our industrial partners was very happy with the results that we provide them. They said that they are working to get a new FDA label, hopefully scale up the solution for other patients long COVID or long COVID clinic at UCLA. They want to prescribe that solution, but also we hear actually good news that at least good news for neurometrics. They said that Electrocore and other larger company acquired neurometrics Quell, and we are hoping to work with them and hopefully bring them on the UCLA. But again, it's a success story that I would like to highlight, that when we build that partnership, when we bridge the gaps, we can make a real impact. We can help to address some of the challenging conditions that we are dealing on every day. figure it out to provide better care to our patient, improving access to care, and that is a win-win for everyone, for us, the students that benefit from this program, the high publication that we have opportunity to publish, to that thank to this great support that we got from industry, providing education for our students and trainees, and also providing better care for our patient, changing the healthcare model, and also benefit our industry members to grow and to thrive and make an impact that is scalable. So we are hoping to continue that success, and we are so grateful for the support again of everyone, our industry members. These are the great team members at Baylor College of Medicine that they contributed to this study. So I stop here, and I'm happy to get any question. So I mean, I'm seeing some questions coming that from Dr. Koronov. Dr. Koronov, please go ahead. Do you have any comments or suggestion?
Yes, it's a question. I think this is great that you're working on neuropathy. It's so difficult to treat. Have you done any research on diabetic neuropathy?
Yes,
You know, that of
actually,
course leads
yes.
to diabetic foot ulcers, right?
Dr. Koronov, one of the earliest study that we published was in your journal, is Diabetes Science and Technology, that
Yeah.
actually we did a study in Qatar, and we demonstrate that electrostimulation impact going on hemodialysis patient. Those who are again going receiving hemodialysis 3 times per week. They're staying 4 hours. They are exhausted. They don't want to engage in any activity, including exercise. They have fatigue and nausea after that. And during hemodialysis, the nurses was very busy. So you can provide exercise, but its management is very hard. And we apply that electrostimulation for those patients, and we find out that we can improve mobility. And also, we saw some of the early sign of the improvement in neuropathy. We apply on diabetic peripheral neuropathy, but we are hoping to apply now for a R1 grant. We are looking for also industry partners to look at it, those benefits for those patient population as well.
I've always had the feeling that long COVID has a significant psychological aspect to it. And I wanted to ask you if you've noticed that or if you're including any psychological aspects to your research.
Yes, this fibromyalgia inventory that we have include some of the psychological factor, because again, fibromyalgia, it's rooted also in some of the perception and leading to depression. We have some metrics of, for example, CASD and mental health. I need to look at the data that how directly we impact those metrics. One thing that I should highlight, except the data that we have in hemodialysis that we reached to 100 individuals, and I believe that we look at psychological factor, and we saw that actually we have reduction in depression. In the long COVID, or sample size was small, so it's very hard to explore those secondary outcomes that we have. But definitely is very valid point. As a matter of fact, it seems that like the ADHD, that not everyone they trying to feel that they have ADHD and trying to seek care. In long COVID, when I talk with our colleagues that they are leading long COVID, they say that many participants are coming even after a couple of years and say that I may have the long COVID symptoms. And some of them, it might be some psychological aspect. Of course, they might be linked to some of the long COVID impact of fatigue and pain that still many people, they claim that they are suffering from it. Still, we don't know honestly much about it. So that's why I would like to uh, making an awareness. We need to pay attention to it. The reality is that many participants still feel that they are suffering from those symptoms.
I have one more comment about this.
Yes.
You know, the symptoms of long COVID are very similar to chronic fatigue syndrome. Chronic fatigue syndrome is very similar to uh, myalgia. There's this, they call it the type of myalgia in England, and that's similar to EBV, Epstein-Barr virus syndrome. My opinion is that this illness, which has a significant psychological component, keeps coming back, and every 10 or 20 years, it gets a new name. And we say, for example, well, COVID, post COVID, we've never seen this before. And we used to say that about EBV syndrome and the others. So I feel that what you need to do with these patients is offer psychological support, but not tell them you think they have a psychological problem as the underlying cause, but rather say they need support to deal with the medical problem they have, even though I think it's not very medical. And then progressive exercise in most cases, and non-habit forming pain pills, and also some use of what we call the antidepressants, especially the SSRIs. That combination has worked. But any kind of a physical treatment that, say, you, Bijan, can offer would be very helpful. So I would say you're doing a great job working on it. Put it in a context of something psychological, you'll get the best results.
I fully agree. Thank you so much for that comment. This is the part that actually I talked to Cheyenne and a couple of other industry members. I said that you have some great educational app, AI based, agenting AI. If you can really provide these personalized to provide this social support, psychological support, not only on COVID, many other patients can benefit from it. But you're
Support
absolutely
group
right.
is good also. You
Yes.
can get a support group run by a social worker or psychologist.
Yes, absolutely. Yes. Panta, I'm seeing that you have a comment. Do you want to elaborate on your comment?
Yeah, hi Bijan, great talk. Yeah, my question is regarding IRB. We were working on a different project with a thinner company. We were using more camera for getting data, deoxyhemoglobin concentration data. It and we were working with healthy participants for that. Obviously, it's very different than your case, and it took us almost a year to get the IRB. So I'm curious to know how long it took you to get the IRB approval.
Panta, welcome to our world. So IRB is a tricky one. Of course, for long COVID, during the time was more challenging because many of the trials were shut down, and the safety issue was even more important because the interaction, direct interaction with the patient, imposed risk to our research staff as well. So it took time, but of course, ultimately after 4 months, I believe that we got IRB. But in general, first of all, I would be happy to share the IRB protocol because we have IRB protocol for can't image and we can provide them. I learned that every new institution that I'm going, because the structure of the IRB and IRB panel and what they are looking is different than other institution. It takes time that figure it out
Yeah.
exactly what they are looking for, what kind of information they are looking for. But when you figure it out that what they are looking for, and of course the IRB panel build the trust that you do manage several trials, there wasn't any issue, usually become more straightforward. But it's coming like a grant writing. When you're writing more and more, you know that what reviewers are looking for. So you're providing the languages.
That's right. Yeah.
I remember when you write my first NIH grant and was just validation of the sensitivity of the device. So you would like to see that, for example, how sensitive the system it is to, for example, detect fall
Mm-hmm.
on simulation fall. And usually as engineers, you say that, okay, if we have, for example, 15 cases, that it might be, or 20 cases might be enough to estimate the accuracy and the error of the system, measuring system. But from NIH, they want to see power analyzing and sample size. And I remember at
Yeah,
that
that's
time, wasn't
yeah.
aware of those. So in the IRB, of course, you need to define hypotheses. You need to define
Yeah.
the primary outcomes, secondary outcomes, and many other details that they are looking for. And if you address these, so it's like a grant review, you need to look at the checkbox and it becomes straightforward. So I have IRB that took between 1 month to over a year. Honestly, it's very varied.
Yeah, that's all. That's awesome. One question I have is that so we were working with the more camera, and This device provides a relative concentration of oxydeoxyhemoglobin, and it was very hard. At the end, we couldn't get oxygenation information because the values had no unit. It was kind of very hard to analyze the data. What was your experience with Kent imaging? Was it as hard to get those information out, and whether you got absolute values or yours was also relative?
Actually, we came a very long way, and we were very lucky that they updated the software based of the comments that we providing to them. Lately, ultimately came up to become much simpler to
Mhm.
extract the metrics that we are doing. No, actually, one challenge that we had is even what area you should select to having more accurate information. And I'd be happy to share those information. The focusing on the region that you are looking for, this was another challenge. Of course, the angle of the photography. There were some problems, but many of them now have been fixed. We can't. And recently, we're starting to collecting data. We have probably now over a couple of thousand pictures that we capture kids from different conditions, and it becoming now an instrument that almost every research that we are doing, we are using that product.
Yeah.
Um,
Awesome.
Again,
Yep.
thank you everyone for your time. I know that it's summertime. I really appreciate to attending and also great discussion that we have. Looking forward for the next week. We have a great speakers coming on wearable. That the speaker is not canceled, so that's great. And in fact, in 2 weeks also we have amazing actually talk from one of our potential new members. I hope that you could join. In the meantime, happy Friday and have a great weekend. Thank you all.
Thank you.